looks like it's 1 o'clock Eastern Central Time, so we will get going on our presentation today. Good afternoon, everyone, and thank you for joining another Superior Health Alliance Quality Alliance Roundtable conversation. I see a lot of the same names over and over, so I really appreciate you all being here. My name is Kim Heft, and I'm joined by my colleagues, Elena and Jerry, as well as our guest speaker today, Jenna Heim. In case you're new to these events, we host these 1-hour sessions on the second and fourth Wednesday of the month. The first half of the presentation is didactic, and then with the remaining time, we will have a Q&A session. If there's anything that you'd like to talk about here in the future, something troubling you, bothering you, just struggling with, leave me a message in chat, or when you fill out the evaluation, you could put your suggestion there too. We have used your suggestions for our topics, so maybe one of those will be, one of yours will be one for the future. Okay, in regards to that chat box, you can share your comments, questions, anything that pops into your mind during the presentation. We'll use that for discussion in our Q&A. I also, though, encourage you, you can at any time during our Q&A, unmute yourself and just talk. Sometimes it's just easier than spending the time to type out your question. Now, I always forget to do this, so I'm going to mention this right now instead of at the end of the presentation. I want you to know that our next event is on May 24th, and we are going to be discussing on how to effectively and safely care for your nursing home residents that receive dialysis. So that'll be on May 24th. Now, before we get started though today, Elena, a quality improvement advisor for Superior Health, she is going to put out a few polling questions about vaccinations that we would like to get your input on, and then we'll also give you a few resources too that go along with that. So Elena, what do you have for us today?
Thanks, Kim. I just launched the first poll. So we want to ask you about 3 of the major vaccine types: influenza, pneumococcal, and COVID-19. But we're going to start with the influenza question. So we want to kind of just make sure that everyone has been paying attention to some of these due dates that are coming up soon. That one is going to be the submitting your HCP influenza summary that is due on May 15th. So we just want to make sure that everyone has what they need for that and they have submitted it, or they plan to. And if you haven't yet, and you maybe didn't know quite enough about that and you need some help, you can let us know and we can kind of reach out to you, because we can get some of these answers to the polling questions, or just feel free to reach out to us. We'll make sure that we put some contact information in the chat, because I see there's a couple people that need some help and we are here to help you. The second question that we had is, what month do you start prepping for influenza season? So when you kind of looking to get some resources together to get your clinics set up, what you need for those consent forms, things like that, anything, whatever you consider the start of prep for influenza season, we kind of want to know that too. We will be prepping some of our own resources to get out to all of you. And we were thinking August, but maybe even July, it would be helpful for several of you. And if you answered other on that one, let us know in the chat when you kind of start that prep process. From what I'm seeing in the polling answers right now, it looks like the majority of you have submitted your HCP influenza summary that's due on May 15th, which is excellent. And I see that there are a few of you that said you're going to do it today. And then there are a few of you that said you need some help from Superior Health Quality Alliance team member, like I said. So one thing I wanted to put out there is I'm going to add a link into the chat, and there is a call tomorrow at 1 p.m. Eastern time to get more information on the HCP influenza summary. So that is some reporting that goes into NHSN. So that page there that I linked you to has the information for that call tomorrow. And it also has some more information on, like, if you wanted to just look at something before you went in, you feel like you have a good handle on it, maybe you don't need help from Superior Health, you could take a look at that first. But as always, we're here to support you with anything like that. So you can also reach out to our team, but we'll also try to grab these polling results here very shortly and look to see those of you who said you need help. Okay, so I'm going to end this poll, and thank you so much for answering those first questions about influenza. The next poll is going to be about pneumococcal. So let me get that one going. So only one question here. We've started to hear that maybe there have been some questions out there about having a good understanding of pneumococcal vaccination timeliness. So when people need to get those vaccines and which vaccine to get. I know that there's been some changes there and there are a few different options. So we want to kind of get a lay of the land here to see how people are feeling about these. Good proportion of you are saying that, yes, you do feel like you have a good understanding of those. A couple people have said no, and a couple people have said not sure. So one exciting thing I can mention here too is that next month in June, we will have one of our partners from Visit Health, he's a pharmacist, come on to talk about the pneumococcal vaccine. So for those of you who have some no or not sure, that will be a really helpful call to be in on, and we'll make sure to give you all the updates like Kim just did about the next call prior to that call happening. But in the meantime, I want to share a cool resource that is out there that I think is really helpful. So I'm going to post two of them in the chat here. They are the same, but CDC has a really cool resource called Pneumorex Vax Advisor. And I posted both of those links in the chat here. That top one is just a web-based format, and it allows you to kind of answer questions to identify what pneumococcal vaccine to get. So let's say you have a resident that you're trying to figure out which one to give them. Click through that, kind of answering the questions on behalf of the resident to identify what pneumococcal vaccine would be best for them. The second one is kind of the same exact thing, but it's an app that you can download on your phone. So if that's easier for you to walk into a resident's room and have that available on an app format instead, that's your alternate to that first resource. So really cool resource that exists. I think those are kind of always easier than trying to keep your eyes straight on a screen looking at something that's showing you some different options, because you know they have your PCV 20 and you've got PCV 13, you've got all of those, and it's hard to kind of keep track of which one is which and which one to give when. So those are a couple great resources for that. All right, now our last poll is going to be on COVID-19. So are you still identifying residents who changed their mind about getting the COVID-19 vaccine? So do you have new residents coming in and still getting that? I see some yeses already coming in. And then our second question here, with the end of, that should say the staff vaccination mandate, sorry about that, do you think any of your staff members will be more likely to get the COVID booster? Got pretty mixed bag here overall. So we're still seeing that there are lots of residents, it sounds like, that are changing their mind about getting the COVID vaccine. And maybe you answered no because everyone already got it in your facility. So that could be another one that maybe I should have added a question or an answer in for that, but still seeing a lot of yeses, which is really great news. One thing I will mention is that if you're having trouble getting access to the vaccine, or you just don't have enough staffing to put on your own clinic, please let the Superior Health team members know. We do have access to partners in all 3 of our states in the whole region that can help with free mobile vaccine clinics. So if you're interested in that, please let us know. Like I said, we'll put some email addresses in the chat here. I'll make sure you have access to mine in just a few moments, and we can make sure that we get you hooked up with that. And then the second one, with the end of the staff vaccination mandate, it looks like we're thinking, by and large, most of you are saying that no, we don't think that they're going to be more likely to get the COVID booster, even though that's not mandated anymore. So just kind of interesting to see what we're seeing and hearing out there about those two things. And just as a resource for that one, I'll post in there in case you weren't aware about that change with the staff vaccine mandate. That came out of the White House, maybe early last week, I think. So there's a link there that kind of describes that. So really appreciate you taking the time to answer those polls. Hopefully you found some of those resources helpful. And like I said, I'm going to put my contact information in the chat. And if you need help with the influenza summary reporting, or if you need help with a mobile vaccine clinic, please don't hesitate to reach out to me at ebear@improve.health. So thank you so much. And I will hand it over to our speaker, Jenna Heim.
Thank you, Elena. Thank you, everybody, for joining us today. My name is Jenna Heim, and I am a quality improvement advisor with the Superior Health Quality Alliance. My background, I'm an RN by background, and I was with a CCRC, primarily in the skilled nursing facility as a director of nursing for 15 years, as director of nursing for about seven and a half years. So today we're going to be talking about falls and keeping residents safe. First, we're going to start off, by talking about, so here's your objectives for the day. So we're going to identify how to use root cause analysis to drive immediate intervention, intervention identification immediately post-fall. You're going to be able to identify strategies for reducing alarms in skilled nursing facilities. And you're going to be able to identify fall interventions that are alternatives to alarms. Some statistics, some recent statistics from the CDC. So we're seeing about 36 million falls reported among older adults each year, resulting in approximately 32,000 deaths. And each year, about 3 million older adults are treated in the emergency department after a fall-related injury. 1 out of every 5 falls causes an injury. And each year, this one was really alarming to me, 300,000 older people are hospitalized each year for hip fractures, and 95% of those hip fractures are caused by a fall. So those are some big numbers, especially that last one there. 300,000 is a big number, and then 95% of those being as a result of a fall. So big topic to keep our elderly population safe for sure. So talking about root cause analysis, I'm sure this is not a new concept to any of you, but I'm just going to kind of go through 2 different types of root cause analysis. And then we're going to talk later on in the presentation about how you can use root cause analysis in your post-fall process to better identify specific interventions that will help prevent further falls. So the first type of root cause analysis that we're going to talk about is the fishbone or cause and effect diagram. So, and there's a link here to the fishbone diagram resource that's available to you. This exact resource or template is available to you on the Superior Health Quality Alliance website. So for this one, you're going to start out with these outside green boxes, and under each category, you're going to answer the question why for the identified problem. And then once each category is completed, you're going to discuss the various causes in order to get to the root of that problem. So the next type of root cause analysis that we're going to talk about is the 5 Whys tool. And again, this is a template or a resource that is available to you on the Superior Health Quality Alliance website. So with the 5 Whys, it's a very similar tool, just a little bit less busy in visual aesthetics. So with the 5 Whys tool, you're going to, again, first begin by identifying a specific problem, and then you're going to ask why 5 times. Why is it occurring? And then you're going to continue to ask why. So a good example of this, I'm going to talk about a specific fall in the facility where I was director of nursing, and just kind of show you how this works. So the resident fell, staff found him on the floor near the window in his room. So the first question we're going to ask is, what's the problem? The resident fell. Why did he fall? He was self-ambulating. Why was he self-ambulating? He was, and then when we asked him, he was attempting to close the blinds in his room. Why was he closing the blinds in his room? It was nighttime and he was getting ready for bed. So then that brought us to the actual cause then of that fall. And we were able to implement a specific intervention, being we close his blinds when he's getting ready for bed, right? So using that 5 Whys tool to drill down to the root cause of the fall being not because he was necessarily self-ambulating, even though that was a factor, but the root cause of that fall being that he was trying to close his blinds because it was nighttime and he was getting ready for bed. So that became a part of that particular resident's nighttime routine. And we were primarily a short-term rehab skilled nursing facility. And so that was the only fall that particular resident experienced while he was in our facility. So successful intervention. So now talking about more specifically, what types of root cause analysis can you use to really look at those post-fall in different factors? So looking specifically at environment, are there trip hazards in the immediate area? This isn't very common in skilled nursing facilities, but if it's in a home setting or an assisted living, or are there rugs? Are there things in their way? Is it, is it cluttered? Is the assistive device that the resident is supposed to be using within reach? There's a thinking a lot of times that if the resident is not supposed to be ambulating on their own, that we put that assistive device, that walker or the wheelchair, far away from their bed so that they can't reach it, under the assumption that if they can't reach it, they're not going to use it. But really, that's just demonstrated that they're going to still get up and try to ambulate, but be more likely to fall, because not only are they ambulating by themselves now, but now they're ambulating without their assistive device. So always better to keep that assistive device within reach. Look at the floor. Was the floor wet? Was there, maybe they spilled their bedside water? What's the noise level? If it's at night, do they have a room close to the nurse's station? Is it shift changed? Is there a lot of chatter at the nurse's station? What's the lighting like? Do they maybe need a night light? Look at the dynamics surrounding the bathroom. If they fell in or around the bathroom area, well, when was the last time that they were toileted? If they potentially made it to the toilet, actually look at the contents of the toilet. Were they able to get to the toilet and void, and they fell in maybe on the way back to their room? Really look at the dynamics of that. If they're incontinent, we'll look at their brief. Was there a wet incontinence brief maybe? Then you can maybe look at, do we need to implement a toileting schedule? Look at the timing of the fall. Is it evening? Are they maybe experiencing sundowning? Is it shift change? Maybe it's on a weekend where there's fewer staff. Look at the trends. I even trended like days of the week when I was director of nursing. We found that there was one particular day when we were having care conferences that falls were occurring more often because a lot of our staff were tied up in care conferences. So looking at those times when you don't have a large staff presence on your floors and seeing if you can identify those trends and if your fall rate is higher during those times. Other factors might include lack of sleep. Is the resident confused? A lot of times, especially in like a short-term rehab dynamic, even if there wasn't confusion prior to the hospitalization and going into a short-term rehab, if they had a surgery at the hospital and underwent anesthesia, a lot of times there might be confusion when they're in the short-term rehab that the family wasn't aware of, or that's maybe new for the resident. Were the recent med changes? Are they on a pain pill? When was their last pain pill? Maybe they needed a pain pill. Actually ask the resident, especially if they're not confused, what were they trying to do before they fell? Thinking back to that example that we talked about with the resident that was closing his blinds, actually ask them. A lot of times they're able to provide really great insight into what exactly they were trying to do before they fell. So one thing that you can do, the fall pick-me-up was something that we had implemented. It was a part of the fall incident report, but it was the actual tool in which the staff utilized root cause analysis in order to determine that new intervention. It was completed immediately post-fall with all staff in the area, not just nursing staff. So it included housekeepers, maintenance, upper leadership, executive team, anybody that was in the immediate area was involved in that post-fall huddle. You'd be surprised sometimes the insight that a housekeeper or a maintenance staff can bring to the table that maybe nursing staff isn't even thinking outside the box like they're able to. And in order for those staff to be prepared for these type of being pulled into these types of huddles, all staff upon new hire orientation are educated on that fall culture and the dynamic of potentially being asked to be involved in these post-fall huddles. So then they're keeping their eyes and ears open, especially if they're noticing a resident's behavior or patterns. So then they maybe can provide some insight into these post-fall huddles that maybe the nursing staff hadn't noticed or weren't aware of. So then this post-fall pick me up as well as the incident report was reviewed the next morning in our morning stand-up meeting with the IDT or the interdisciplinary team. And we discussed that immediate intervention that was implemented, whether or not any adjustments were needed or we thought it was appropriate as an IDT, and made appropriate adjustments, made sure all of the physician was notified, the family was notified, and everybody was okay with that new intervention, made sure the care plan was updated, and that the resident was okay with the intervention as well. So now we're going to switch gears a little bit and we're going to talk about alarm reduction. So if you're still using alarms in your facility and you're potentially considering doing an alarm reduction initiative, if you're just getting started with that initiative, here are some considerations. You're going to want to consider resident and family buy-in. They're not as hard as the staff buy-in piece of it, let me tell you. Budget and resource, you're going to want to consider care plans. If you've got standardized interventions or interventions that can be automatically selected in your EMR and you're doing an alarm reduction initiative, you're going to want to think through making sure that those types of interventions are removed from those options in your EMR. Staff education, you're going to want make sure you want to provide the correct education and the why and the rationale behind your alarm reduction initiative. Staff are a lot more likely to buy in per se if they understand the why behind why you're doing something. Project name and activities and a timeline for your initiative. You're not going to want to have alarms one day and then tomorrow we have no alarms. That's never going to work. So then talking a little bit about the rationale behind why you would want to reduce alarms in your facility. So with alarms, staff reaction is actually counterintuitive if you think about it. So the usual staff reaction when an alarm goes off is to tell the resident to sit down. And if you think about it, when you're baking cookies or putting anything in the oven, you're going to set a timer to remind you so that you can temporarily forget about the cookies or the baked good or whatever it is that you're putting in the oven so that you can move on to another task. And then when you hear the timer, that reminds you to pay attention or check on those cookies, right? So alarms then cause a reactionary rather than an anticipatory nursing. Sit down versus a what do you need? And then alternatively, noise has actually been shown to be a common cause or a contributor to fall. Again, it's counterintuitive to everything we've ever learned or have been taught since childhood about what we should do when we hear an alarm. Think about a fire alarm. We're taught to drop, roll, get out, do something. You're never told to sit still, don't move, sit down, don't move, sit nice and still in your wheelchair when you're hearing a loud noise. So it only makes sense that if a resident, especially if there's any degree of confusion with these position change alarms, if they hear that alarm go off, they're wanting to move because that's what they've been taught since they were a child. Talking about the specific updated F tags associated with alarms. So there's at least 4 updated F tags that talk about specifically those position change alarms. So there's F584, safe environment, 604, respect and dignity, 689, accidents, which we're going to go a little bit more into detail about, 725, sufficient staff. And then, so the requirements of participation state that for residents, a position change alarm may potentially act as a restraint, actually. So if that, and I'll click we'll go on to this for the critical elements pathway for accidents. And this slide that you're looking at is word for word from the CMS critical elements pathway. So this is what the surveyors are looking at when they're determining whether or not to cite your facility on these position change alarms. So they're looking at what evidence is there that the device has actually been effective in preventing falls. Is there evidence that this device has had the effect of inhibiting or restricting the resident from free movement out of fear that the alarm is going to go off? So thinking about a resident that maybe isn't confused, or maybe just a little bit, and they're in the common area with their peers, and they know if they shift their weight at all, that alarm's going to go off, and they're maybe embarrassed about it. They're not going to shift their weight at all because they don't want that alarm to go off. And we know that shifting their weight every now and then is good for their skin integrity, right? So it's not a good thing for them to have their weight on bony prominences and not shift their weight around at all. So that's where surveyors are looking at it as almost a physical restraint, because it's the resident is scared to move for whatever reason. Maybe the alarm going off scares them. Is there evidence that the alarm is used to replace staff supervision? So going back to the cookies in the oven, are we setting a timer so that we can temporarily move on to another task, knowing how many tasks there are for the nursing staff to do in a skilled nursing facility? Is that alarm just the timer on the oven? So when it goes off, then we go and check on that resident? So now I'm going to talk specifically about the alarm reduction case study. So the specific alarm reduction initiative that I did in the facility where I was director of nursing for 7.5 years. So at about year 3, I had a new administrator come into my building, and he was shocked to find that we were still using bed and chair position alarms. We maybe had one door alarm. We had numerous alarms in the facility, and I couldn't, he asked me why we did, and I couldn't imagine a world where we didn't, because we used them so frequently, because we were a short-term rehab facility and we were not a locked unit. So those alarms really were our way to, and we had a wander guard system, but the alarms were a key piece to our fall prevention program, especially with confused residents. So our fall process before I embarked on this alarm reduction initiative, we identified whether or not a resident was a high fall risk upon admission based on a fall assessment tool where it resulted, we took into consideration their diagnoses and their medications and their ability to ambulate independently, things like that. And we were given a number at the end. And then if the number was higher than 15, they were considered a high fall risk. If it was lower, they weren't a high fall risk. So if they were considered a high fall risk, we placed it was called a falling leaf on the outside of their door frame. So that way all staff knew that if they had a leaf, they were considered a high fall risk, and they should at least peek in, lay eyes on that resident, and make sure that they were safe. Standardized interventions, meaning that kind of a knee-jerk reaction for my admission nurses, that if the resident was coming in on admission and had any degree of confusion, we put them in a room as close as possible to the nurse's station, in a low bed with a fall mat and a position change alarm. After a fall happened, we would maybe look at specific interventions related to the cause of the fall, but more often than not, we had saved one of those standardized interventions, saved it back in our toolkit on admission, so that after a first fall, we could implement if we hadn't done a fall mat, well, let's do the fall mat now instead of looking at that root cause of the fall. So again, these were the kind of standard or typical interventions you would see before we did our alarm reduction initiative: bed and wheelchair alarms, position change alarms, door alarm, low bed, fall mat, room close to the nurse's station, increased visibility. My nurses use a lot to keep the resident in the common areas, which wasn't always great for the resident, and frequent checks. Some of the hurdles and challenges that as director of nursing I experienced to this initiative before I even implemented it was, and this is coming from my nursing staff, the family wants us to use them. It prevents a resident from falling. Gets me to them faster if they're on the floor. That was an infamous one. The resident has dementia, and then any number of things they would say after that. And then the most common one was, we don't know what else to do. So what I was tasked with, this was approximately a 3-month timeline that I laid out for this initiative. What I was tasked with was coming up with a set of interventions that I could empower them with, that would enable them to have a toolkit per se of interventions they could implement if they didn't know what else to do, where they would, before they would automatically implement an alarm. So we came up with some pretty unique different interventions, in addition to really that pick me up form with the post-fall huddle. One thing that we changed about that with this alarm reduction initiative is we required staff to, we had a big empty box on the top of the back of the form, and it was a paper form, I know. But it had to be paper form because I required them to draw a picture of the fall, whether they witnessed the fall, so draw it in action, or more often than not, draw a picture of how you came upon the resident, including if maybe their walker was tipped over next to them, or if there was water on the floor, or if they were in the bathroom. What the picture did was it allowed us to really scrutinize that intervention and whether or not it was actually appropriate to the root cause of the fall at our discussion in IDT the next day. A lot of times the physical and occupational therapist would get involved and maybe make slight adjustments to that intervention based on what they saw in that picture. There was sometimes we would have stick figures. Sometimes there would be artists. It just depended on who was working, but they always drew, they were very, they always drew the picture, and we always got some really good insight to the dynamics of that fall based on the picture, as well as the questions asked in that root cause analysis as well. I'm sorry, feel free, anybody, to jump in if there are questions. I know I'm talking kind of fast, but feel free to jump in if there are questions. Okay, so then let's talk about the updated interventions, this toolkit of interventions I provided them. So an anti-skid mat to chair or wheelchair. So this was something that we found and purchased. It was a tubular kind of a mat, and inside of it had Velcro. So we would place it on the chair, and the resident had the ability to scoot as far back in their chair or wheelchair as they wanted, but they couldn't scoot forward. So if the fall was occurred because of the resident scooting out of their wheelchair or the chair, or sliding forward, or for whatever reason, a fall from a chair, this was a great intervention to implement. You know, if we had somebody that was pedaling themselves around in their wheelchair and they would get themselves scooted all the way forward, these little anti-skid mats were great for keeping their butt far back in the wheelchair, and they could pedal themselves around and their butt wouldn't move. It was great, really effective. The other thing that we offered as an intervention was these anti-slip strips to the floor. I looked for a picture of them, but I couldn't really find them. So what I want you to imagine is the kind of hard, coarse surface that is on steps. It's like a gray We had it in gray, we had it in yellow, but we could place those strips anywhere needed, in front of the resident's bed, in front of the toilet, in front of their chair. Oftentimes in all three locations, the housekeepers had a little bit of pushback with those strips on the floor with room changeover, because they were a little cumbersome to get off the floor. But once they came up with the right, they used some sort of a glue gun, I believe, in the end, and found the right product to use, and then it was no problem. That was a really great one to use. Motion detected light strips under the bed. So this was a great one for those residents that were cognitively intact and able to take themselves to the bathroom at night. So it was a kind of a sticky strip of lights. It was motion activated. You could attach it right to the bed frame. So then when the resident would swing their legs over the bed at night, and you could set the timer of it so that it was only activated at night, when they would swing their legs over the bed, it would light up. I had one resident, she loved it. She would refer to it. She said it was so bright. She referred to it as kind of her semi truck, like lights on a semi. It would allow her to get to the bathroom. And then by the time she was finished in the bathroom and came out of the bathroom, it would pick up her motion coming out of the bathroom and light up her way so that she could get back safely into bed. So then we, the other thing that I wanted to briefly touch on as a new intervention that could be utilized that a lot of times isn't thought about is if there are varying levels to the floor height, a lot of times simply giving that some contrast, some different contrast to the different floor height levels will help the residents too, because a lot of times their vision doesn't allow them to see that depth and that different height level anymore. So just giving that a different kind of a color or contrast was another thing that we did a lot. We eliminated entirely all alarms, all low beds, all fall mats, and 15-minute checks. 15-minute checks are never reasonable. Staff aren't actually doing that every 15 minutes. It's just not something that's sustainable or realistic. And furthermore, it's something surveyors are always going to catch you up on, in my opinion. Now, the reason that I eliminated low beds and fall mats, and the reason that you don't see that as a part of this alarm reduction presentation, is because my research way back when I did this alarm reduction initiative in my facility, the research showed that fall mats and low beds were no longer recommended. They were actually shown to be causing more injury than preventing injury. If you think about needing a bed to be at bed height so that you're kind of sitting at waist height to be able to stand up appropriately. If a resident is trying to stand up from a low bed and they've got a fall mat right there, they're kind of lunging themselves forward, was the thinking. In my research for this presentation, I found that low beds and fall mats are still very much recommended for skilled nursing facilities. So while we eliminated them at the time, that is not my recommendation. They are still very much recommended in the skilled nursing facility setting as a fall prevention initiative or intervention. Just happened to be a part of our particular case study at the time. So the other big change that we made to our entire fall process with this alarm reduction initiative is, instead of doing that fall risk assessment to determine if a resident was a high fall risk or not, we instead looked at all residents in our facility as a high fall risk, simply based on their need for skilled nursing facility placement. So instead, we identified their fall injury risks. So instead of that falling leaf, we instead determined those fall injury risks, which could have been these 4 different categories. Age, if they were over the age of 85. B for bone, if they had a diagnosis of osteoporosis. C for coagulant, if they were on aspirin, Coumadin, Plavix, any blood thinner, they got a C. S for surgery, if they had a recent surgery within the past 30 days, they got an S. So we had a large laminated sheet of paper on the bulletin board in every resident room that kind of went into detail about these different A, B, C, and S identifiers. But then once the admission nurse identified each specific resident's fall injury risks, they would explain those risks to the resident. Also, how to prevent injuries with a fall based on their specific fall injury risks. And then these identifiers, because all the residents knew what they meant, and we didn't want these being on the outside of the door frames like the leaves, we had these on the inside of the resident's door frame. So then the explanation was right there in the room. If the family was visiting, they could educate themselves. And then it was a nice reminder for the residents on their fall injury risks and what these little letters meant. And then finally, post-implementation monitoring. So these are things that I made sure to monitor as director of nursing, especially after I implemented this initiative. And so during this 3-month timeline, it was a slow workup. The resident and family buy-in, that was easy. I met with them, they were 100% on board. It was the staff buy-in that took that longer period of time. So in the months leading up to our go live date, especially in the couple of weeks before, I held very brief 5-minute, we did ice cream socials. So 5-minute presentations, they could come in, they could have an ice cream sundae, and I would do a 5-minute PowerPoint presentation, just reiterating time and time again, all of these different things, and really just drilling into them the rationale behind this so that I could get that staff buy-in, because I knew it wasn't going to be an effective initiative if I couldn't get my staff buy-in. So then you're going to want to make sure after an initiative like this that you are obviously, as always, watching your quality measures, especially your fall rate and your fall with major injury. Was there an improvement in your fall rate after your initiative? Was there a reduction in fall related injury? And then you're also going to want to look at the correlation between falls and noise levels in the facility and time of day. With the initiatives being specifically with alarm reduction, obviously looking at noise levels is going to be what you want to look at to make sure that that was indeed a good initiative to implement in your facility. I'm not saying that all alarms are a bad thing necessarily. I understand that, you know, some facilities are different, and maybe you implement it in steps if your facility has different dynamics, but this was the way that we did it. It ended up being very successful. My project name, we were on a prairie. I did a lot of research into, I wanted it to be quiet something. So I did a lot of research into animals that started with a Q that were quiet. And so we came up with quiet quail. And I have nurses that still work at that facility that still refer to, whenever somebody talks about implementing an alarm, they always say, oh no, we follow quiet quail around here. So it's stuck in their head. So you want it to be fun and light because there is going to be pushback. And so in order to get their buy-in and to really have them advocate for your alarm reduction initiative, that's how I was able to be successful. Any questions?
Well, Jenna, right now, there is a question in here, and this is regarding if this presentation is being recorded so that we can listen, so other people could view this. And yes, it is. It might take a couple of months to get it on our YouTube page, but I have that pasted here. I got it in chat. So you will find Jenna's presentation. Again, give it a couple months, and others, our other roundtable events are on this link right here. I'm scanning here on the chat questions. I don't see any at the moment, but does anyone have any questions? Please feel free to unmute yourself. Are the slides available? I believe that has been put in there a couple times. If you can't find it, maybe Jerry, you can throw that in there one more time for everyone. And it gets lost in chat sometimes. It looks like we do have a question. Are you able to see any of these questions, Jenna? If you want to, you can stop sharing so you can see your chat. Might be easier. Not that I can't read them, but it's always nice for you to be able to see them too.
Sure, good idea.
Get back to my chat here. So Rita is asking, can you clarify recommendations of low beds and fall mat use in nursing homes? What did you find again? You heard your studies showed one thing, but
absolutely. I apologize for the confusion. So when I did my alarm reduction initiative, this was approximately 7 years ago when I did my alarm reduction initiative. And at that time, 7 years ago, there was research out there that demonstrated or that shown that and it was kind of like a hit or a miss, but I believed that the research was geared towards not utilizing fall mats and low beds because there was a possibility of residents having that nosedive dynamic if they were attempting to get up out of bed. However, when I was preparing for this presentation in the previous few months, that is no longer, all of the research is pro low beds and fall mats. So all of the research out there is very much pro, especially if you've got a resident that's falling from bed. The research out there says that implementing a low bed with a padded fall mat is a very effective intervention, especially for residents that are rolling out of bed. So definitely still a recommended intervention. Fall mats and low beds are still recommended.
Yeah, Jenna, I think you hit, that was like the nail right on the head there, because you wouldn't want to put this intervention in for someone that is trying to stand up, take a few steps, they get on the fall mat, now they can't stand on that fall mat and then they fall. You got to look at your person and what it is exactly you're trying to stop from happening from that injury.
Exactly.
And Rita said, thank you. Anybody else have any other questions?
I do have a quick question. So I know that there are some facilities that treat falls like a code and so forth. And so can you expound on the treatment of falls like a code, because they're doing the root cause analysis at the bed, but that does take other individuals off the floor. What has been your research around that?
Sure. In my experience, so there's obviously, depending on the circumstances of the fall, the staff always want to for sure get an RN involved right away so that RN assessment can be completed. And then the RN will make, based on her assessment and other staff being available, for other residents if needed at that time, depending on, again, the circumstances of that fall. But with it being a skilled nursing facility and there being RNs in the facility, also then again, depending on time of day and those different types of dynamics, having to call in and talk with a physician immediately post-fall, being part of the skilled nursing facility requirements. Obviously if there's a dynamic where there's a head wound or anything like that, or a suspected fracture, then we would always discuss with a physician. We used the Interact tools. So I would have the nurses fill out the SBAR form, talk with a physician, and then discuss whether or not there would need to be a transfer to the emergency department, or if it's something that could be monitored in-house, depending again on the circumstances of both the fall and of that particular resident, whether they're there for short-term rehab, or maybe they were a palliative care resident that was going to stay in the facility, depending on those types of circumstances. But for sure, if there needed to be a transfer to emergency department, then that could occur fairly quickly in a skilled nursing facility after the RN assessment. Thanks, Makisha. And so I don't see any other questions right now. So I just want to touch base, or maybe do one more. So I just want to touch base. Recently at the Leading Age Wisconsin conference, again, this is for Wisconsin, we don't have the data for Michigan or Minnesota. I'm assuming it's probably fairly similar, but at the Leading Age Wisconsin conference, they talked about the top 10 sites for the first quarter of this year. And so F689 accidents was number 3 on that list. And so specifically, they were looking at falls from bed, and then falls involving a Hoyer lift, in which 2 different dynamics with a Hoyer lift: a correct sling not being used, and then not having a 2 assist with that Hoyer use when it was care planned that a 2 assist was needed. Do any of you guys have any experience with those types of issues?
Yeah, I wonder if, getting 2 assists sometimes is hard to do. And it doesn't even mean with just a Hoyer either. And yeah, I can remember, yes, that there were,
Right,
that
like
did
whatever
happen
care
at
plan,
times.
that's what you have to be doing, right?
Right, yeah. Has
You
it,
can't
does
have a
it?
care plan as 1 to 2. You can't have the CNAs making that decision. That was
Correct.
something I learned early on in my career in skilled nursing facilities. CNAs can't make that call. And if you've got a care plan, if the physical therapist says 2, it has to be 2, even if there's only 1 CNA on that floor and you've got to call one up from downstairs, has to be 2 for the safety of the resident. The other F tag that was on that top 10 list that I found interesting was coming in at number 7 on the list was F684, maintain well-being. And that was related to not having a full RN assessment immediately post-fall. So 2 different categories were heavily related to falls. So it's definitely, and just looking back at those statistics that we talked about in the beginning, it's definitely an area where we want to make sure we're super diligent just to protect the residents and prevent those falls with injury for sure.
So Jenna, you made me, I was thinking about something you said in regards to your using the anti-slip strips and also the lights under the bed. 2 comments. The one on the strips, we used to use those too. And I just have to think one step further with, if you're using it, just make sure that they're not getting old, they get dirty. And then, so it's who's looking at that? Whose responsibility? Is that a checklist for a housekeeper, or is that a checklist for the maintenance department to look at those strips? And also with it, now see, I didn't use these under the bed lights, but are they battery operated? Who's
Nope, they plugged into the wall.
They plug into the wall. Okay.
A roll of sticky lights, a strip of sticky lights, and they would stick on the bed frame, and then they plugged right into a wall.
Okay, but just again, one of those, this is an intervention. So who's maintaining that they're working, right? That they're still, it's just something to keep, think about, because I think we get immune to that, where you're like, when did that stop working? I didn't even notice they weren't going off, right?
Yeah, that particular resident that had the semi-truck lights under her bed, she wanted them rearranged a couple of times, and she wanted her bed rearranged. Her and I worked together to rearrange her semi-lights several times. But in terms of the anti-slip strips on the floor and those getting old, our average length of stay was 19 days. So that's why the housekeepers got a little irritated, because they were very frequently having to remove those strips. So they had to remove them more often than they got old. So we use them pretty frequently. And my infection control nurse was also very on top of making sure they got replaced. If they were coming up at all, if they were becoming a trip hazard at all, then we had to replace them. Obviously, we didn't want a fall intervention to become a cause of a fall, right?
Thus far, I don't see anything in chat. Again, if you have a question, please feel free. You made me think though of something. Oh my God, this is I used to like really, this was like a hot topic for me too. I did a lot of like fall prevention in the building I used to work at. And one of the things that I found difficult, and I would love to get some feedback from everyone, because it probably isn't just me that was having this issue, is the fact that you got down to this root cause and you implemented that intervention. You said the blinds is a great, like, yeah, shut the blinds. Yeah, you put it in the care plan, but it seemed to get lost. It got lost. Certain interventions never held true. We couldn't follow through with them for different reasons. Does anybody have any suggestions for that?
Kim, it's Jana Broughton. How are you?
Jana?
So taking it back to QAPI and doing a PDSA cycle on looking at why the blinds aren't getting closed at night and involving the people on afternoon shift. I think sometimes we forget about those opt shifts when we're looking at root cause analysis and solutions being implemented. And if it's an unrealistic expectation for them, then maybe we need to look at the device and figure out how we make it easier for possibly the resident to close their own blinds, or put some type of shade on the window that prevents the sunshine from coming in that is closed on afternoon shift, perhaps, and you care plan it. So, but really taking it back, just because the first time doesn't always succeed doesn't mean it's a bad intervention.
Yeah, those are great ideas.
Perfect.
That closing of the blinds, fall and intervention came after our initiative, by the way. So after the root cause analysis and all that post-fall huddle. So prior to the initiative, we wouldn't have got that specific for sure. So I was so happy to see that one.
Very cool.
I've already gotten an email about this. I want to give one last reminder about that influenza healthcare personnel vaccination module in NHSN. May 15th is the deadline for that. If you aren't sure what I'm talking about, please shoot an email to one of our team members and we will make sure that you get what you need to fill that out. It is within NHSN. You might need to activate it in order to see it. So if you need any information on that, please reach out and we will get you what you need so that you can meet that deadline of May 15th. So just one last reminder on that.
All right, well, I don't see any more questions in chat. So I do want to thank you, Jenna, for a wonderful presentation, and thank everyone. I thank everyone too for your participation and giving us insight, and everyone helping each other, in the struggle to prevent falls, because it's definitely a hard thing to do for our nursing home residents to keep them safe. So I appreciate you all, and I hope you all have a great rest of your day and week. And I hope to see all of you again on May 24th for the managing of dialysis patients, your nursing home patients. So take care, everyone. Thank you. Bye-bye.
Thank you.